Great to join you this morning for me. I'm not sure what time zones others are in, but I'm sure afternoon for some, for this conversation. I'm excited for this conversation because we really think about our role as shaping incentives. It's about shaping the structures to push forward innovation, not just about the way the government drives innovation and can innovate, but aligning things so new things are created by private enterprises. Um, I mean, I think I have good ideas, but I'll confess, like when I hear ideas from others and look around the world, it is a much richer place for all the different innovative ideas that different sources bring. Whether it's investors, whether it's doctors who just hit on an insight as they're caring for a patient and are like, wow, wouldn't it be great if the world had this? And looking at drug discovery to new technologies to just different ways of engaging care, experimenting on how patients respond. It is such a richer place when we unleash innovation. And the flaw with the government-centric approach to healthcare, that a fee schedule, which is how we pay for care, literally, we have a schedule and we pay fees for the things on it, is that we pay you for doing the things on the schedule. We direct that innovation in ways that might not be as intentional as we might wish, and we really curtail it. We put it in a box, we put it in lines, and that's not good. Whereas comparing that with a market-driven approach, where what you have is actually I will pay for that. And oh, if even if I won't, they will, and they'll choose to pay for it, and we push forward and innovate in different ways and we reach people and engage them, we see innovation flourish. Our role at the Innovation Center is about trying to break us outside of that box. Go outside of the fee schedule, go outside the lines, and color new pathways and see what emerges. And so when I think about the grant of authority that Congress gave to the Innovation Center, I think it really should be used to try and set up programs that are relatively open-ended and enable people to push forward and innovate in different ways. And you see that structure reflected in the push towards accountable care entities for many years now from the center, and in what we've come forward with newer versions of that, as well as opening up the aperture to technology companies to directly be reimbursed by CMS for the delivery of care to patients. And so I was excited to come into the Innovation Center because the Innovation Center is the part of the largest payer in America that Congress has entrusted with thinking through these approaches. And I see our role as trying to open up that aperture and think through approaches that might surprise me. I don't know what will emerge. And so participating in conversations like these are exciting because I can highlight the opportunities, but also learn from the conversation with some of the interesting people who I know will join the panel today in the conversation around how they're thinking about it, how they might approach the program, how they see the market aperture. I am also very, very aware that people struggle sometimes to join our programs, to navigate what all the different acronyms mean and see the, requirement on page 63 of the document and say, oh, we didn't comply. And so I try and make it a bit more understandable as well. And so that's why I'm excited to join you for this conversation.
Yeah.
It's also great to see you again as we worked together years ago.
Yeah. So Abe, if I'm understanding you correctly, it's almost like you're thinking of these new programs as not so much programs as like new frameworks within which other opportunities can flourish. So it's almost like a new uh, testing grounds where you're going to allow people to innovate with different payment models or different things, and then potentially see how it pans out, and then determine from there what might make sense to solidify. Is that how you think about it?
That's exactly right. And one way to think about it is we could do a test where we can very, very narrowly define what needs to be done, structure how we pay for it, and then people go and do that intervention. Or we could say, we'll pay you for an outcome, and you figure out what intervention you want to do to achieve that outcome. And there needs to be an element of the first spirit in what we do. That's how we get confidence of, yes, there is a pathway to do an intervention to have an impact, but there also should be a healthy spirit of the broad aperture, particularly when risk transference is involved, because then we can really have a degree of confidence that, we're not in a loss scenario. That is one thing we try and avoid. We don't want to set up models where there is a real risk of the government losing money. And, the investors on this call might say, hey, that's short-sighted because taking risks will get you large returns and not every bet needs to work out. And we have that attitude, but we also don't want to have to pull the plug on something early and undermine the investments people have made. And so with
Mhm.
that attitude, we've tempered our approach somewhat.
Yeah. And also part of it seems like is laying out a relatively long time frame for some of these programs to play out so that you have opportunity for people to invest knowing that it's several years, in some cases it's about 10 years down the road. So there's time to design a program and play it out.
And that's exactly right. And that's that same spirit that's driving that. We want to ensure that there's confidence to come in. I want people to be able to go to their boards and say it makes sense to invest in this and justify the decision. And so that longer timeline hopefully influences that conversation as an investor or a CEO is making a decision about how to position a company.
Yeah, that makes sense. So tell us about some, I mean, there's a long list of programs, but some of the ones that you feel like are having the most impact right now on the kind of healthcare innovation community. In my mind, I think it's probably Access and Elevate, but love to hear which ones, if you could like walk us through just a little bit of the basics of what you're trying to achieve with each of those.
Of course. And Access and Elevate get at different problems, right? You could call them both prevention, right? One is Access, for those less familiar with the model, is a track that is really about achieving an outcome-aligned payment for the management of a patient with a chronic condition. So cardio, kidney, metabolic health, musculoskeletal, or behavioral health conditions. And it is a monthly payment plus a payment for the achievement of that outcome. So things like A1C levels improvement. In contrast, Maha Elevate is really about elevating the evidence base for different interventions that maybe people have paid cash for in the past, or maybe people have had in the commercial market. So similar in spirit to Access, where people have had access to digital therapeutics, but not about broad access across the program in a 10-year test, but about a limited intervention with a couple of hundred patients where we'll get the data on how did that work? Did it improve outcomes at all? Did it lower costs? And if it met those standards, then look at a broader expansion or broader test, depending on the evidence standard met. Importantly, we are not telling anyone in the world what those look like. We're saying open call, give us applications. We've got a couple of hundred applications in for our first cohort. We'll be selecting 15 of those later this year, and then we'll put in a call next year for another 15 to come in. So both of these, different people can bring creative ideas in, similar. Both of these get at a prevention goal. One is really in some ways, programmatic change, whereas one is a
Hmm.
limited set of gathered data. So probably different scale of immediate impact, but over time, things that come into Maha Elevate may become real benefits that are perpetual in the Medicare program. And so there's a real potential there as well. And we're getting engagement and excitement on both of these models. I might also link one other model, which also involves technology. So in our grouping, somewhat similar to Access, but it's had a narrower set of participants, and that's the Wiser model. And
Hmm.
Wiser is really about use of prior authorization in original Medicare on services that are actively harmful to patients where we've had no real review to date. And so if you want to improve the quality of care and lower the costs of care, which is what our statutory mission is, preventing harmful care from occurring is a pretty good way to go about doing that. And so it was very logical for us looking at this to say we should do this review. Now, the catch of why we wouldn't have done this in the past is you don't want to slow down access to care, particularly in the cases where it's most appropriate. And so building in a structure where we had technology review and auto approve people very quickly where it's appropriate was important to us. And then being able to pioneer a gold carding approach within the program so the vast
Hmm.
majority of physicians get completely exempted was important. But between Wiser and Access leaning in on technology and Access and Maha Elevate leaning in on prevention, I think those highlights two of the real themes of what we're trying to do, which is capture the promising innovations of new technologies and new approaches to care that we're seeing outside of the Medicare program and give them a pathway into Medicare. Give them a pathway for the 70 million beneficiaries of the Medicare program and then the beneficiaries of the Medicaid program as well. And we're getting at 150 million Americans who can benefit from different approaches. And that's a big market. That's a market people want to invest in to serve. And that if we could align the incentives correctly, we could really push forward and have a better standard of care at a lower cost and at a more affordable cost for the American beneficiary.
Yeah, that makes a lot of sense. For a long time, we've been talking about in health tech innovation, it's been hard to access those markets because there wasn't a really good pathway. So I'm excited to see that play out. I'm curious what the market reaction has been. I know you've been out there at conferences talking to people, maybe more so than previous administrations, really kind of trying to hear what the market is saying. And I'm curious, what are you hearing? Do people, are people excited about these programs? Are they, obviously, you've had hundreds of applicants to some of them, but love to hear what the market reaction has been.
It has been broadly positive, which is helpful. We've also gotten some helpful feedback where we've been able to go and put out clarifying, frequently asked questions to try and reassure folks and get the information out there to ensure that there's not unintentional barriers to participation and not unintentional things that impede operational interventions that people want to do. And so those conversations have been helpful both for myself. I'll call out Jacob Schiff, our Chief Technology and AI Officer, and some of the other folks on the Access and Wiser and Maha Elevate teams. We've gotten a ton of insight, and so please keep that coming our way. Uh, the largest critique and concern we've heard is that people think that achievement of these outcomes is going to be difficult to do within the access structure, and that we are paying at rates that make it hard for them to be set up for success. And I think that's a fair critique. We're giving a challenge to the industry that is really geared towards people who want to make the investment and experiment and see what they could do, and reach the scale at which, even if it's a low margin per beneficiary, at a couple of million patients, it's a very good business that makes sense to invest in. We don't want to be paying for really, really involved, expensive interventions that we don't have confidence will pay for themselves. That's not really our statutory mission or our interest area. And so it makes sense that some people react to this and say, hey, that's not for us. And that's okay. Every person should make a decision on what is in the best interest of their patients, their providers, their shareholders. But other people have looked at it and said, actually, that's an opportunity because we think we could innovate and we could develop agentic solutions. We could develop solutions that are lower cost, and we will have the barrier of other folks not choosing to come in because they won't want to deploy an expensive intervention and realize losses because of that. And so that feedback has actually validated the thesis, and the large participation that we've seen has validated the thesis. It remains to be seen, can people actually deliver now? And I'm sure people will iterate on their approaches and improve over time. In the wiser model, the main critique has been, will this inadvertently prevent patients who should have access to these services from accessing that care? And the answer we give there is that we are taking a very, very intentional approach to stay close to turnaround times, to review decisions to ensure care is appropriate and that care can be accessed. And so we have a 72-hour turnaround time requirement, and we are closely monitoring participants. We've already initiated an audit on one participant and gotten information that way and also helped correct and course correct with them. And so that's been the main critique there. On Maha Elevate, I have not heard a specific concern really articulated from many places. People largely look at it as sort of a revamped version of the Healthcare Innovation Awards that's a bit more focused on prevention, given that we realize today that going upstream is really the critical aspect. So I focus on the three that we've been discussing,
Yeah.
but people give me feedback across the board.
Yeah, I saw a recent debate between you and another kind of blogger, I guess you could say, about some of the programs. So I guess I'm curious, Abe, just very tactically, how should people give feedback? Like what is the best way? Like, is there an inbox they should be writing? What's the tactical way to do this?
So please send me emails. That's like one way
Okay.
to do this. If on particular models, there is also a web address up on the model homepage that
Okay.
says please send us feedback here. And there's also particular folks involved in each of these models. So when I get the email, I will typically loop in the relevant folks to help
Hmm.
people connect and help make sure people who have way, way, way more expertise and also way more insight into why operational decisions were made to structure programs certain ways. But we do engage. We do think through. And sometimes it's a question we've gotten before or we have thought through intentionally and have a ready answer. Like, we appreciate why this is hard for you. This was intentional. We're proving something out. We're experimenting. And that's just the way it is. But sometimes our answer will be, oh, tell us more. We didn't expect that. That's surprising to us
Hmm.
because even though we've operated, we've been in private sector roles. We've different folks on our team have founded companies, invested. We also are now in government. We also are now in this place where we live and breathe regulations, not live and breathe operations. And so, keeping us sharp on what you're seeing is helpful and may change our actions.
Yeah. That makes sense. It's interesting. It seems like the government's really leaning into agentic AI. I mean, pretty much said it. It's very tech driven. I know we'll hear from Alyssa a little bit later, who does more tech enabled services. So we'll talk about that. But it's kind of interesting to see almost like a leapfrogging on the government side to really go all in on technology. Last question before we bring in the other panelists. How are these programs named? Is someone sitting around with ChatGPT to come up with these awesome acronyms?
There is definitely a lot of iterating with different LLMs. Um, we also do try and we think through a couple things. One, I am not partial to the three-letter acronym that doesn't stand for a word, and it's hard for me to understand what it means when I hear it. I like something that's catchy, that sounds like a program where like, oh, I know what it is. Two, I would love if when I hear it, I actually can connect and distill what this one is about. That's a helpful thing. Um, and so, as an example of that, Guard was really, really catchy. Globe was really, really catchy. And I think thematically, you could get at like we're looking at international prices from Globe. We're protecting U.S. pricing from Guard. And then when we get to the Medicaid space, we want to be generous in our approach to it. And all of them start with the letter G. So the MFN models thematically go together. On balance, lifestyle interventions, GLP-1 access, both of these are what is necessary based off the FDA label indication to sustain weight loss. It seems like balance is really the core of how we should be approaching health interventions here. And so that made a lot of sense to us. Maha Elevate, we're elevating the evidence standard. It's inspired by the whole movement to make America healthy again. It really resonated. What you're basically getting from this is I have a lot of fun naming. This is like the favorite part of my job. I'm sure so folks here have been involved in thinking of names for companies at different points. It's probably the same exercise that you go through. And so, that's what we do. We try and think of it. The
Yeah.
one thing I will say is nice is I am less concerned about trademark infringement than you all are. I'm like, oh yeah, that's fine. Let's just go and infringe. I'm sure there's someone from the legal team at CMS who's going to watch this and be like, wait, no, that is not our approach. We do a review. Um, but we're less concerned about confusion because we tend to jump up on the Google search results and on what anyone will give
Yeah.
rather quickly after announcing a name.
Yeah. Well, I hope that as much detail, thought, and kind of nuance is put into the programs as to the naming, and then I think we'll be in good shape.
I can't claim that. Yeah, the naming is really where we focus, and then we try and back solve and think of models afterwards just to match them.
Awesome. Well, thank you so much, Abe. So please stay on and we'll welcome to the stage Alyssa, Anand, and Anish. Thanks for joining us to bring some of the industry perspective to this. And maybe we'll just really quickly go through and do intros. Alyssa, do you want to start?
Sure. Hi, everybody. Alyssa Jaffe. I'm a partner at Seven Wire Ventures, where we invest in healthcare technology companies that help people to become better stewards of their health. So we really think about healthcare technologies and services meeting people where they are. And for us, we really focus on partnerships with both financial institutions, but also strategic organizations, plans, providers, pharma, employers to really help facilitate growth with our companies. I'm operator turned investor and just really happy to be here. So thanks for having me.
All right, Anand, do you want to go next?
Sure. Hey, good afternoon or good morning, everybody. Anand Iyer, Chief AI Officer, Welldoc. Welldoc is a mission-driven company that takes AI-driven software as a medical device and provides that to both patients and providers in the digital health space. And we specifically cater to the cardiometabolic condition space, some of the conditions that Abe mentioned, like diabetes and hypertension and obesity. With over 100 peer-reviewed publications and journals and 11 510(k) clearances from the FDA, this is true software as a medical device. And our healthcare-ready AI really provides what you would call safe and personalized, clinically validated, almost turn-by-turn instructions for patients to, kind of optimize, if you would, whether it's a glucose outcome or an obesity outcome or a hypertension outcome, et cetera. We are very proud to be one of the companies alongside the CMS access model and health tech ecosystem at the finish line, eagerly awaiting the full launch of the program. And I think we're just excited because everybody will attest, anybody who's even touched this program remotely will attest to the speed at which we're moving, the acceptance of understanding and making pivots here and there as we go along, kind of flying the plane and building it at the same time. So I think we appreciate the energy and the spirit of innovation that CMS is driving here, and excited to participate in this discussion.
Awesome. Anish?
Very briefly, an advisor to Anand, former colleague of Alyssa's 20 plus years ago, a friend of Abe. So this is one family. Love you all. I currently chair the Arcadia Institute, which is sort of the research wing of Arcadia, which is population health and outcomes delivery for a lot of leading health systems and plans. And then I currently, or have been in government. I was a former U.S. Chief Technology Officer and try to help bridge that public-private handshake that Abe referred to earlier.
Awesome. And somehow we, to go along with Abe's naming conventions, we made sure all the panelists' names start with A, otherwise you weren't allowed on the panel today. But to kick us off, I'm going to ask, what are the trends that you're excited about in health tech right now? Where do you see investment, focus, and innovation going? Alyssa, why don't we start with you?
Of course. No, thank you. I feel like I can't I for also love Anish's one family indeed. I like to say, my kids are too little, but as they get older, there's no such thing as strangers, right? We're all connected in really unique ways. So it's interesting. Thank you for the thoughtful question. We can't do a panel without obviously talking about generative AI and what AI has done to healthcare. And truly, it's been the most transformative thing to have happened to our industry in quite some time, if not forever. But I think as we think about the application use case, you asked what gets me excited. Sure, there's a lot of ways that we can hopefully drive some more cost efficiencies, workflow automation, back office support. But really, where we focus our time is how AI can help with provider enablement and not provider replacement. And so happy to talk about what that means and where we think there's ways to better deliver care. Abe talks about a lot of the programs that they're now offering, the embracement of technology, but that doesn't mean the replacement of the care team that's put in place. It's just how to create an extension. And so we often feel that there's, real momentum here. From an investment perspective, these are the kinds of businesses that can take that technology and can scale quite significantly. But we also are strong believers that the biggest impact, the biggest outcomes, and the biggest exits in healthcare come when you empower people to be better stewards of their health, right? When you give them access to information, connect them into the system, have the system connect back to them to improve their own health outcomes. No one wants to be a patient, right? Patients are people that have things done to them. Consumers are active stewards of their health. And so that's where we focus.
Yeah. Anand, do you want to share your perspective?
Absolutely. I'll build off of what Alyssa said, which is when you think about it, the concept of AI is not novel, right? Sir Alan Turing, 1956, teaching a machine to do what a human would otherwise do or think. And buried in that definition is, if you would, multiple forms of AI that span what we call state vector machines or rules-based engines, okay, all the way through machine learning and deep learning. And then, of course, as Alyssa mentioned, the new kid on the block, generative AI. And I think what's exciting about this space is that you can actually have solutions that take into account all of these. And the reason I say take into account all of them, as a regulated medical device, there are certain things that you may not want to pass on to an API endpoint that's a generative AI. You may actually want to provide a rule that says, look, for this high risk situation, if their glucose is above a certain range or below a certain range, always do X because that's aligned with the clinical guidelines. And so I think what's exciting and the trend we see is not one form of AI, but multiple forms of AI coexisting, if you would, within a single software as a medical device product. And I think that's great because you're right, Alyssa. I think I always say this that AI won't replace the doctor. I'm not a believer in that at all. But I think doctors who use AI may very well replace doctors who don't. And for me, it's allowing them to see what's not visible by the naked eye alone, right? It's like looking up in the nighttime sky and you see a point of light and it's a planet or it's a star. You know, this week we're going to see Venus and Jupiter side by side. But when you look in the Webb telescope, you see multiple galaxies at that same point of light. And I think AI is to the doctor and to the patient what the Webb telescope is to the astronomer. It lets them see beyond, if you would, what they can see with the naked eye. So I think that's really cool. We're illuminating these new treatment pathways. And then maybe just two other things. One is the concept of the digital health experience chain or the digital therapeutics experience chain. The Advil is only as good if they swallow it, right? The headache's not going to go away if they don't swallow it. So in many ways, patients have to use these solutions. And so from identification to onboarding to engagement to outcomes, if we draw that continuum, I think it's very, very important for us to understand what are the forces along the way that encourage one to participate in a system like this and use it such that it can deliver its intended use. And then lastly, I think this notion of public-private partnership, Anish touched on it, I think this is a necessary ingredient that's setting these programs apart. It's not that the government is saying, hey, go do this, we're going to regulate. No, this is a very different, innovative, market-driven approach that Abe mentioned. I think this trend is very exciting, and it's a trend we see elsewhere, and it's a trend that I think we have an opportunity to leapfrog on.
Anish, what about you?
Well, let me just throw a little bit of cautionary perspective. At the moment, AI has largely been inflationary to the overall healthcare ecosystem. We've seen provider adoption with upcoding, payer responses with auto downcoding, and to some degree, it's a reflection of the challenges we have at the underlying infrastructure layer and within the economic model that our uniquely American public-private healthcare delivery system has sort of fostered. I want to amplify Abe's comments and his colleagues at CMS who've launched something called the health tech ecosystem. So as we think about this notion of market shaping, that they be designed in a way that is deflationary to the overall healthcare budget while improving quality. Kudos to Abe for launching Access as a predominantly deflationary model. He could have easily ticky-tacked the other way to just put a billing code on AI. And his doing the outcomes aligned payment really is a market signal that I think it's important to amplify. But so too are the issues around the underlying data infrastructure. AI run on fragmented patient records may not get you the answer you're looking for. So you gotta have the ability to aggregate health information at the point of trust, a place where consumers can directly delegate with the access program. They can pick directly. I mean, Abe didn't put a referral mandate, so I can go direct to the App Store in Medicare in July and have my mom access an access clinic, which I'm intending to do ASAP. And that entity hopefully will put in as part of its onboarding process the ability to aggregate the patient's health records that CMS is now making much easier with the health tech ecosystem. But it also means value-based care entities that are already under some broad mandate to kind of bring about deflation can incorporate some of these emerging capabilities within their operating model. They're not mandated to use Access or mandated to use Wiser or Elevate, but it sure seems like a great set of tools in the toolkit to facilitate. So if you are an innovator trying to bring a deflationary force, a productivity enhancing force, and you want to get compensated for that work, there's never been a better time to be an innovator than now.
Yeah. It's really interesting that several of you touched on this idea of the underlying forces, and there's something about AI that makes everything move faster. But if we don't solve the underlying pieces, we're just moving faster toward the same challenges that we've had before. So are there any kind of ways you think folks who are, potentially innovators in the ecosystem listening here can think about how to address some of those underlying forces. I think that example of the prior auth between payer and provider is a perfect example of a challenge where we're kind of piling technology on top. So what about almost like setting aside the AI question? Any thoughts on how folks can really address some of these underlying issues?
Maybe I'll start one of the things that I think is challenging as we think about innovation in healthcare is a lot of folks from general tech world want to come in to healthcare because it's so enticing, right? Everyone's had their own frictions with the US healthcare system. Everyone's had their own experiences. And so, there's a lot of appetite and demand to try to fix. The problem is a lot of that comes with some perceived naivete around what it means to actually build a sustainable solution in healthcare. And I find that those who try to build around the system without the incumbents, without the support of CMS, right, without working within the existing infrastructure, end up falling short because direct to consumer cash pay models just only last for so long. That's really not where the majority of our country is. That's not where people's financial status is. And so I think those that say that they embrace the incumbency, those that really say, how can I partner with a plan, with an employer, with an integrated delivery network, right? With a lot of those who bear the risk of the cost, end up being the ones that we find, for better or for worse, end up scaling. And I'm sure Abe will say this too. Whether we like it or not, the keys to the kingdom are often held with the payers. And so, figuring out how to unlock those relationships becomes a real way to drive innovation, as we think about tech, not even just AI, right? But as we think about services, technology, and just furthering the betterment of healthcare in the United States.
And if I'm to build on that, Sari, there's in my mind there's several challenges, but if I boil it down to a couple that I think are worthy of discussion, one is on the patient side, how do I truly use AI to drive that level of personalization? As a type 2 diabetes patient myself, if I've incurred 3 hypoglycemic readings in a week, me getting some LLM message about the merits of exercise and how it affects my diabetes is wasted, right? At that point in time, I have that captive audience moment when somebody could have told me something about how to perhaps avoid hypoglycemia or signs to look for. And so I think personalization, all the AI practitioners should be thinking about the delivery at the point of care. How do you drive this personalized, right? At the same time, on the yin yang side of it, these solutions have to be integrable into care flow as we know it today. Okay. You can't ask an overworked, underpaid doctor to do one more thing that's orthogonal to their workflow. They won't do it. Doesn't matter how flashy or how sexy it is. So integrability, it doesn't just mean data interoperability that Anish said, okay? It's workflow integrability, it's process integrability, it's aligning such that the AI helps them support, if you would, the realization of their own quality measures, HEDIS, STARS, et cetera. So I think clinical workflow integrability is really important. And then I think the other challenge, just as an AI practitioner myself, is I think there's just a lot of noise in the industry right now. There's just a lot of noise. There's a lot of people who claim they do nothing but AI, but their AI really does nothing in reality, right? And so I think this is an opportunity for us to say, using, for example, the FDA has been very clear now about the differences between general wellness, okay, enforcement discretion, class 1, class 2, clinical decision support. We have an opportunity to align with these established frameworks. We have an opportunity to deliver meaningful impact that's consistent with delivering quality care and safe care at scale at a low cost to the deflationary points made. So I think some of those things are the things we need to look out for as we engineer and architect these public-private solutions.
It's interesting that you mentioned some of the noise and the players. One question I was going to ask you all is, lately there's been all of this talk of the forward deployed engineers. I don't know if that's the new buzzword you've all heard as well, but we've seen a number of kind of partnerships and different modes where consulting companies, big AI companies, or like big LLM companies are all coming and saying, hey, we can help you go in and design your own solutions. I actually heard the head of healthcare for Anthropic speaking, and he was telling a room full of health systems, don't buy vendor solutions anymore, just make your own. And so I'm curious how you think about that from the different perspectives. I'm sure, Alyssa, you have a perspective for having seen your companies have to maybe deal with that. But what do you think that is? Is that a trend? Is that something we should, expect? Is that good? Is it bad? What do you think?
And you see me chuckling over here because like the build and Anish too. We've been working with health systems a long time, and the build versus buy discussion. This is not the first nor the last time we'll hear this. In addition to but can't Epic just do this? I mean, those are probably the two biggest. And ultimately, as you think about the history of the incumbency, unfortunately, they don't have the resources or the ability to move the ship quickly enough. You look at early stage businesses, they are just moving at lightning speed. They're taking greater risks. They're investing in their solutions. They're finding really innovative partners. And so, I'm it's curious to hear that somebody gave that advice, because I would say actually in conversations with health systems who, I spend a lot of my days talking to a lot of the strategics, that's not the rhetoric from them. The rhetoric from them is, why would I build this myself when there's so many amazing solutions out there? The challenge that they're having now is they're piloting 10 to 20 companies, and now they don't really know exactly what to do, as they think about more of the enterprise-wide scale. And so I'm sure Anand has thoughts on this, as he's done a really good job of, scaling and building a solution. But, ultimately, I don't think that there's much of an appetite for them to, make these investments. I'll give you an example. One of our portfolio companies, Transcarent, they work with self-funded employers. They work with health plans. They really help, bridge the gap in health and care for member populations. They invested $100 million into their AI solution. It's pretty hard to compete with that, right? When you're a provider-led organization with very thin margins, you'd much rather partner with one of those companies than you would try to take that type of capital yourself and compete against it.
Anish, any thoughts to offer?
I do, and I'm mindful of I could throw 1,000 forward deployed engineers on a fragmented patient record to argue that they need the low value back surgery, and that should not be the winning profit seeking entity that leads to an outcome that's not high quality and lower cost. And so I'm mindful that there are like these two competing forces. Let's start with base principles. The US commits to a public-private healthcare delivery system. We're going to stand on that premise for as long as, I hope, our organizations. We want the power of innovation, but we want it driven towards a better system for all people. That requires us to get the rules of the road right and have an economic incentive that rewards the best possible thing. What I'm grateful for with Abe is he's decoupling the highly complex shared savings, benchmarking, and algorithmic, complexities as the only way to drive accountability, to now include this much more, I guess, easier to administer capabilities around access, elevate, and I would even argue wiser. So the real moment we're in is whether we can get the rules of the road collectively deployed in the industry such that then you can add your forward deployed engineers and so forth, because you're going to be rewarded for doing the right thing and not to exploit the currently broken thing that is easy to exploit. Now, what are the three things I think we have to get right? Number one, we need to finish the work of the health tech ecosystem. Consumer access to all of their health records to connect it to apps of their choice. Number two, we need to make sure that every provider is on at least one network where they're willing to share with a trusted provider partner and a health plan who's trying to work on quality and payment integrity. And last but certainly not least, we have to activate the employers in this effort. And I think kudos again to Abe. When they announced Access, a bunch of Blues plans and other commercial employers said they were going to bring Access. So what that means to me is if there's a signal that is, self-insured employer plus CMS, that's a much more defendable investment signal that Alyssa might support than one that's like, let me do something dedicated to a narrow, specific noun, a CMS model that has all this complexity and pray that it like shows the value and scales. I think having these sort of horizontal, easier to administer capabilities to get the rules better will be the most important thing. So data infrastructure and payment rules, and then unleash the ecosystem.
And then maybe one thought to add, building on both Alyssa's and Anisha's thoughts, is doing that, what Anish just described is exactly the right path forward. Doing it requires a certain modularity in people's solutions. And in the past, our healthcare solutions were tended to be monolithic. Okay, you start to think about what, Epic, it's kind of an all-enclosed system, and you can't really plug and play and do what you need to do. The concept of modularity is only exists when you have interoperability. But you can't have modularity without interoperability. And so if rather than saying, hey, I Anthropic or I OpenAI or whoever it is, come in and let me help you build your own. No, there's a ton of good investment in a lot of good programs. The question is, how do you pick the ones that are right for you, and how do you assemble so it becomes a configuration exercise rather than a build or buy, right? And so I think the programs that we're putting into place. So we see, for example, going one step beyond just the Blues, Anish, and the commercial payers who said that they would like to also embrace. There's some 14 of them who signed up and pledged and said they would like to extend. You also have the whole creation of the Rural Health Transformation Program down at the state level, and so the states are being given the opportunity. They're not being told. They're being given the opportunity to say, "Hey, here's a model that is we're trying. We're hoping to see success both on the uptake but also the outcomes." But now we start to replicate this pattern, not just for Medicare, not just for Medicaid, for commercial, but also for, you start to think about rural. Now you're starting to create critical mass in the approach. And so I think this model is one that we should all pay very close attention to. This model inherently brings public-private partnership, which forces us to think about modularity and using best-of-breed solutions, bringing them together and configuring them in a way that makes sense. And then we have to worry about all the things that we need to worry about. As soon as you bring two things together, you got to worry about cybersecurity because there's a new boundary that you didn't otherwise have. You got to worry about these things, but those are known unknowns. Those are things that we can solve for. So I think these are all things that we should go kind of eyes wide open as we scale these types of programs.
I wanted to jump in on this one, but it largely to make the point that Anand just made on configurability as opposed to buy versus bill as a false binary. I will confess I am mostly motivated in speaking up on this point because I'm married to a forward deployed engineer. But setting aside the personal motivation there, I do see a value in the role of coming in and helping systems operate new solutions and configure them, data hookups, ensure they're set up, ensure their teams are trained on them, which is what that role is about. And so I do not expect the entire world to say, oh, we're just going to take the general models and we will build our own solutions completely. I don't think that is efficient for all the points that Alyssa made. But I also don't think it's just I'm going to take this off-the-shelf solution, throw it into the ether, or employ all the engineers who set it up and hook it up, because I don't think that's efficient either. And so Anand largely hit on where I expect us to go in this world, at least from the existing health system perspective, while at the same time, there will be people who are not saying, let's sell to the existing health delivery system, but let's stand up an alternative delivery system, who will be more integrated players, tech native, standing up their own solutions completely.
Yeah. I'll invite the audience to put any questions you have in the chat. I'm going to ask one more, but then we'll hopefully leave a couple of minutes. So my next question is, when we think about really tactically for innovators who are listening, whether they're within companies that are existing or entrepreneurs, where do we see opportunities over the coming years? And Abe, I'll actually start with you. Of like, what's kind of the idea on the horizon that you're thinking about, if you're able to share anything about what might be coming, or what kinds of other programs you're interested in, and then we'll turn to the other panelists for broader perspectives.
This is the danger of going off mute, I guess. I I would say that like the best way to start is what are the use cases that you wish existed in healthcare today? And like I have a few that are on my mind. I think there should be more ways to take risk. I realize that's the other extreme pathway of what Anish was praising that we're doing, but I wish there was more ways to take full risk on different specialties, right? And I think that would be an interesting use case and pathway. Right, coming down the pipeline is the geo ahead approach. So geographic ahead is something that we've released a light amount of information on, but there's more coming, where you'll be able to say, I don't want to optimize on the fee schedule. I also don't want to look on the narrow use cases CMS chooses to lay out. I want to take on total cost of care accountability without needing to partner with the existing care delivery system. And I will push AI doctors towards people. And I will, develop my approaches and do whatever it is. I can't impact the FDA's authority through my models or what the state will license, but I can say from the CMS perspective, we'll give you that total cost of care accountability without imposing additional barriers. And then it's on you to take on in the 4-year period that you hold the risk on the patient, what interventions you will. And so I think that's something that folks should be paying attention to, where I'm excited about where it goes. I think there's more we could do on care navigation as a particular use case, where there is a need to help people find their way through the system that is often confusing. And so there are a couple of things that we're thinking through where we love ideas if people have them.
Thank you. Who wants to jump in next?
Let me
Anish, go
just
ahead.
double down on there's an intersection here I want to highlight. The term I'm using is a health information fiduciary, an entity that is operating in the best interest of the patient and not necessarily the sponsoring entities in terms of all the fragmented parts of the system. Small little anecdote. My mom is one of the Medicare beneficiaries who was first to use the Claude aggregate your health records feature that was part of the health tech ecosystem. And she had the ability to pull in all of her health information. And she had a bit of a scare. Her doctor said she might have a form of cancer, multiple myeloma. She freaked out, family freaked out. But we worked through it methodically and we got, hey, order this test to get this answer to be at ease. And she was able to do that on her own without having to there was no quarterback, even though she's got like a whole bunch of doctors that she sees. She then, I didn't know this, she signed up Abe for a high deductible med sup plan. I'm like, that's weird, Mom. Why'd you do that? Well, it's super cheap. It was great, whatever. She's using AI to find, she needed to get a foot MRI for something. She's like, did you know I only paid $37 in copay because I went to this outpatient thing, and when it was going to be at the local health system, it would have been $1,000. My mom literally was like making the case that like she's now equipped with information in a way that she never was before. And I love my mom, but she's not like some PhD physics sort of, Silicon Valley entrepreneur. She's a wonderful, thoughtful botanist. Okay. But my point is, a health information fiduciary should do what my mom was able to do. And at the current model, there's no shared savings that rewarded the conversational AI to route my mom towards the higher quality, lower cost facility. So Abe, in terms of care navigation, it was sort of a free gift to America that this was there. But like that is not the norm. Instead, we're having a fight in Washington about site of service savings. We should mandate that those should be delivered as opposed to having the market naturally encourage folks to go to the place that's better for them. So that capability that marries the data aggregation, the insight generation, the routing, that is a hole in the system today that's not rewarded. We called them blue button apps back in the day, but we had no business model. So if we could figure that out, I would think that could be a big impact. And Alyssa's right. The employer market's done more of this, and I'm an advisor to Transcarent. They've got this nailed. We don't have that in the Medicare program.
Well, Anish, your mom needs to teach. My parents are still using too many emojis when they text, so maybe your mom needs to give mine an AI lesson. But I love that. I think that's where there's such, again, we talk about the democratization of health and information, and There's nothing better than people getting the information that they need, right? We do not live within inside of the four walls of a provider's office. No matter what we do, or even the most frequent flyers, you still, the best way to manage health is to empower people. So maybe I'll answer the question a little bit differently, which is, I know there's a lot of entrepreneurs on the line, and truthfully, one of the things that people do, I don't think spend enough time with in healthcare, is actually thinking about, are you solving an actual problem? And who has that problem, and who bears the cost or the risk of that problem? And so I think it kind of just actually goes back to business fundamentals, and it's not just about product market fit. We talk a lot about founder market fit. Why are you and your team the right people to build that company? Because truthfully, healthcare is the get rich extremely slow strategy. So it is really about, there's massive opportunity, but you have to love this and care about this and have a passion beyond just trying to flip a quick buck. And so I think those that really focus on problem solving are the ones that end up being quite successful.
Okay, we have a question actually, which is a little complicated. So Eric, do you want to voice it over? It's a bit long. You can come off mute and share the question and see if we can get folks to answer.
Yeah, no, sure. Well, first of all, thanks for doing this. All the panelists' comments have been great. And I was thinking about Anish when you were talking about the infrastructure layer that really needs to be in place. I work with both ends of the innovation equation, a lot of enterprise organizations, and at the same time, a lot of very innovative, early stage companies that are doing things at a remarkable pace. And I hear a lot about this sort of too many point solutions, and yet it might be translated into, well, maybe that infrastructure layer isn't where it needs to be to support the very personalization and precision-oriented diagnostics and therapeutics that people are looking for. So, how do you think about that, and what would motivate these organizations to really invest in the infrastructure that they need to support the innovation that's occurring at a rapid rate?
I'll be a brief, just to describe for you how I see the world evolving. And this is Anish's opinion. I don't speak for any government agency. What we have right now are rules in the books, the Cures Act specifically, that has called for this sort of open platform for healthcare data sharing. And it's bipartisan, like 90% of Congress voted for it. Its constraint and why it doesn't exist is it sits on the shoulders of a rickety piece of our regulatory machine, which is that we can only regulate that which has, quote, evidence of industry adoption. So if there isn't an open platform where you could have multiple services connect and this configuration that Anand described about, we can't make that the default for the whole country. So what CMS did last year, which I think is really a clever approach, I embrace it, didn't think of it, was let's recruit early adopters to generate, quote, evidence of industry adoption. We've succeeded in that. My mom used a product that was born on a kind of this commitment. So here's how I think the movie will play. Number one, we have enough evidence of industry adoption, and will be by July 30 when the next health tech ecosystem milestone hits, that should give the two regulatory bodies the power they need, and a third signal. One, that CMS starts to mandate as a condition of participation to be in the Medicare program that you must connect to a network. Doesn't say which network. The powerful thing this team did was say there's no one road to rule them all. There's a million options and there's no barrier to entry. You create your own, but you got to be on the network and you got to be registered in the public national directory. Two, the National Coordinator for Health IT has to upgrade all of the underlying health IT systems that they can more easily and seamlessly connect to networks with service level agreements. And that's coming in what's called an HTI 6 rule, which I believe is going to be the big API service level agreement rule. Again, I don't speak for the administration. This is my hope and a prayer. And then third, that the large self-insured employers see the value of this, that they incorporate the same logic into their procurements as they create their own TPA agreements. And AT&T is the first employer to have already done so. If we get the employer market to embrace the platform ecosystem, you hardwire it with the condition of participation rule, and you up the quality of the EHR system so that the cost for an individual health system or a doctor to connect is low, then we'll have the infrastructure layer we need with the rules that Abe is putting out to drive this success. I don't think of this as some kind of complicated triple bank shot. I think it's very achievable if we can do these last few steps.
All right. Well, we have about 30 seconds left. Any last perspectives anyone wants to share? This was a pretty meaty conversation, so I know there's a lot of threads we could pull on.
Maybe just one last thought to share, which is around the whole concept that CMS is driving of partnering up and buddying up, collaboration. Math always works in your favor, right? 100% of a million is always less than 10% of a billion, always. And so there is a innovation rationale, there's an economic rationale, there's a capabilities rationale to collaborate. So I'm excited that that's the path we're taking forward, is this collaborative one where we're fostering, cross-company and cross-industry collaboration to solve this, conundrum, right? So super excited.
Well said. On that note, we will end. Thank you to our panelists. This has been a fascinating discussion, and looking forward to future conversations.